Hi, my name is Dean Wang. I'm an orthopedic surgeon and sports medicine specialist at UC Irvine in Orange County, California. I'm going to talk a little bit about a study I conducted during my time at the Hospital for Special Surgery in New York. This work was done in conjunction with Brenda Chang, a biostatistician, as well as attending surgeons from the sports medicine service. In the last several years, within orthopedic surgery, there's been an increased interest in defining a clinically meaningful patient outcome after an operation. Much of the older literature that reported on clinical outcomes after cartilage repair defines success by statistically significant improvements in patient-reported outcome measures, or by means of failure, typically defined as conversion to arthroplasty. However, statistically significant improvements don't always correlate with clinical differences that are perceived by the patient. And patients treated with cartilage restoration generally consist of a younger population and therefore may cope with pain for many years and do not undergo arthroplasty. Therefore, there's been an increased emphasis on using metrics such as the minimal clinically important difference, or MCID, and a substantial clinical benefit, or SCB, to define surgical success. At the Hospital for Special Surgery, the majority of cartilage restoration procedures consist of osteochondral grafting for chondral defects of the knee. These consist of osteochondral autograft and allograft. And therefore, in this study, we sought to define the MCID and SCB after osteochondral graft treatment for cartilage defects of the knee. We also sought to identify which patient factors were predictive of achieving MCID and SCB after treatment with osteochondral grafts. And we focused on two specific outcome measures, the IKDC and the KOS-ADL. We used an institutional registry to identify patients who underwent osteochondral autograft and allograft procedures of the knee. And the decision to perform either autograft or allograft was generally based on chondral defect size. The IKDC and KOS-ADL were administered pre-op and minimum 2 years post-op. And using anchor-based methods, we calculated MCIDs of 17 and 10 for the IKDC and KOS-ADL, respectively, and SCBs of 30 and 17 for the IKDC and KOS-ADL, respectively. Using these thresholds in a multivariate analysis adjusted for age and sex, we found that lower pre-op IKDC and KOS-ADL scores were predictive of achieving clinically meaningful improvement on these outcome measures. This is consistent with the results of other studies for other orthopedic procedures, in that patients with higher pre-op scores may have less opportunity for post-op improvement that would meet the criteria for MCID and SCB. Additionally, higher pre-op activity levels as measured by the marks and lower pre-op pain scores as measured by the SF-36 were predictive of achieving clinically meaningful differences after surgery. This fits the clinical picture of patients who are more active in sports, have more muscle bulk and core strength, and less overall pain, and are therefore able to rehab more effectively to maximize their outcome after surgery. Lastly, we found that one or fewer prior ipsilateral knee surgeries was predictive of achieving clinically meaningful improvement after surgery. So in summary, we found that lower pre-op IKDC and KOS-ADL scores, higher pre-op activity levels, less pre-op pain, and a history of one or fewer prior ipsilateral knee surgeries were predictive of achieving clinically meaningful improvement after surgery. We hope that the MCID and SCB values derived in the study are novel additions to the literature that may serve as references for defining clinically meaningful change in subsequent studies.